Good evening, everyone, and welcome to the Orthopaedic Academy webinar program, which is streaming in conjunction with Ortho TV today. My name is Nikki Evans, and I'll be your host for this evening. I'm delighted to welcome Mr. Joe Goda as our speaker this evening, and the rest of the Orthopaedic Academy faculty, Mr. Firas Anut, Mr. Shwan Hanari, Mr. David Hughes, Mr. Justin Leong, and Mr. Sham Ashcott from Ortho TV. The agenda for this evening will be a presentation by Mr. Goda on orthopedic imaging for the FRCS exam, and we'll follow that with an MCQ poll of 3 questions. These are anonymous, so you can fill them in as quickly as possible, and then we'll go through the answers. We'll also have some time for invited questions. If you put your questions into the chat box, then we will ask at the end and hopefully get them answered for you. This evening, we will also do a hot seat practice with feedback. Each Viva session is 5 minutes long. We need 3 candidates who could make yourself known to David or Shwan or Firas. The idea of these is not to embarrass you. We think it gives you the best practice for the exam. So everybody is welcome to volunteer. Just a reminder of our upcoming courses. There they are. The case-based discussion course, which at the moment we're running 2, and the mock exam course, which we've run through the year and has always been very popular and gets booked out really quickly. And that's how you can book them. You can look on our website there, orthopaedicacademy.co.uk, and you can follow us on Twitter, YouTube, and Facebook. And you can also message us to join our Orthopaedic Academy Telegram group. So without any further interruptions, I will hand you over to Mr. Joe Goda, who is our presenter for this evening. Thank you, Joe.
Oh, thank you very much for this introduction. I'm delighted. So I will share my screen. Good. So today we are going to discuss about imaging for FRCS trauma and orthopedic exam. This is a very much and very common asked question in the FRCS, especially, of course, in the basic science, and it will give you some of the information for the other tables as well, like the adult pathology and of course the trauma. First of all, we have to know the regulations behind asking for an X-ray. There is something called an IRMER or IRMER, which is the ionizing radiation medical exposure regulations. And this is particularly in the UK. It is commonly asked in the MCQ, and I believe as well it can be asked in the basic science. And this was done to protect the patients from ionizing radiation. Basically, not all the ionizing radiation, of course, because without ionizing radiation, we cannot diagnose, but from non-essential, non-important ionizing radiation. And it defined 4 duty holders. The first one is the referrer, who is basically you, the orthopedic surgeon, who actually requests the X-ray. And you have to, in the X-ray form, you have to write why you want this imaging to be done. This is how you justify it. Then the practitioner, which is the radiographer or the radiologist, who is basically the one who says, yes, this type of X-ray can be justified and is needed for this to answer that question. Then the operator, basically it's the radiographer who will press the button, and the employer who actually makes the framework for all these duty holders to work. The employer, if you want to do a quality improvement program, this is where you aim to the framework. Then what is the X-ray? Here, the X-ray, you have to have a clear definition to X-rays. It is a high energy electromagnetic waves. I usually study in threes. So 3 bullet points or 3 buzzwords to answer any question. So X-rays are high energy, that's 1 word. Electromagnetic waves, 2 words. And wavelength is shorter than the visible light. That's the 3rd buzzword. If you say these 3 buzzwords, you have the definition on. There's, again, 3 things we need to know in the X-ray. The structure of the X-ray machine, something called the thermo-ionic emission, which is the process by which the X-ray is formed, and attenuation. So first of all, the structure. As you can see, this is the X-ray tube on our right-hand side. There is tungsten filament, which is heated. That's why it's called thermo-ionic. So thermal, so it's heated to about 2,200 degrees Celsius to emit electrons that travel from the negative cathode to the positive anode. Once it hits it, okay, all this in the vacuum tube. Once it's hit the anode, it can hit it in one of 3 positions, either the outer or the higher level electrons, and that produces heat, the inner electrons, and that produces about 20% of the X-rays, and the nucleus, which is basically, it produces about 80% of the X-ray radiation. Remember, from high school, electrons traveling and radiation are more or less the same. There is an interaction between them. This is a basic physics a thing that you don't need to know for your FRCS exam. So then the attenuation, when the X-rays are emitted from the X-ray machine, it hits a body. And it depends about the amount of absorption of each element. So bones have a high attenuation. That means they attenuate or absorb a lot of X-ray radiation. This is in contrast to water or air that has low beam attenuation. So most of the X-rays will pass by. And then there is something called scattering, which is so much important. We will know later in the presentation. This is deviation of the X-rays after hitting something, hitting the object or hitting the thing that you are X-raying. Then we have 3 main types of X-rays. Conventional screen film radiography, which we stopped using it in the whole UK now. Digital radiography, we use it, and fluoroscopy. So the conventional screen radiography, again, 3 things. It's a film between 2 phosphor intensifying the screen. This screen is basically to transform the non-visible X-rays to light, to visible light. So, and then hitting the film to produce the image. Digital radiography is slightly different, although the same principle. It's either that direct radiography or computed radiography. The difference between them is that direct radiography is that the receptors each receptor generates a pixel in the computer. Computed radiography is that you take everything on a cassette and you have to put it in a machine which has a laser light that transforms the X-rays to light rays. And then you have, of course, the computer, which processes the imaging, and you have the PACS system. All of us uses PACS system now, which is picture archiving and communication system. That's where all the images are stored and you can easily see them. And they are a means of communication between the radiology department and any other computer in the trust. Advantages of the digital radiography over the conventional one is basically it's economic, but on the long run, it's less exposure, as you need less X-ray intensity, and it's easier to retrieve. You have it forever. Although the first one gives you a hard copy, but this hard copy can be affected by sun and water. Then you have the fluoroscopy, which is the second main question in the FRCS exam. You have the X-ray tube with the same generating, the same everything, but you have an image intensifier. And here you need an intensifier because the amount or the intensity of the X-ray used in fluoroscopy is way less than the X-ray used in the department downstairs. So the intensifier has multiple levels, from an input window to an input phosphor sheet, which transforms the X-rays into light, and then light to electrons, which actually is transferred to your screen. But the aim of this is basically the single X-ray beam will be accentuated by thousands of times. That's why you can use it. Okay, you take like 10, 20, 30 images in theaters compared to a single image in the outpatient clinic, and still you're in the safe zone. That's because of the brilliance of presence of the intensifier. Then fluoroscopy, it has to be, there is a very important guideline, which is the ALARA. ALARA is basically as low as reasonably achievable. And that is, again, 3 buzzwords: time, distance, shield. So less time of exposure, longer distance from the machine, and the thicker the shield. Then you have the advantages of the X-rays in general. They're good for diagnosis, they're ready, they're cheap, but they have disadvantages. They're ionizing radiation exposure, and it misses the subtle pathology, especially soft tissue, and it's a 2D imaging. Then there is a modification to the X-ray to become a computer tomography, or the CT scan. The CT scan depends on the presence of the donut, which is the gantry. Again, the gantry is formed of three parts. The collimated, and collimated means presence of multiple lenses to actually focus the radiation on the source or on the image that is aimed towards. X-ray source, fan-shaped, that gives you a fan-shaped X-ray beam to hit a collimated detector. To create an image, you have to have the source and the detector combination. That means they have to be perfectly aligned together because they are rotating in the gantry, and that's how they produce the image in the CT scan. So basically, the X-ray and the X-ray tube and the X-ray detector actually are against each other, and they have to be precisely aligned. After having the image or on with the X-ray beam, they rotate a full rotation, and then the whole gantry, or basically the bed of the patient's bed, moves. When it moves, another circle or another cut is taken. That's how it's linear movement of the gantry. This produces something called a voxel, not a pixel. So rather than a dot or of either a black or white color, no, it produces more or less a rectangle or a cube. So what are the types of computer tomography? Again, there are 3: conventional, helical, which is basically the movements of the X-ray or the detector, and the gantry are linear and continuous. Multi-detector, which can give you a 3D image. Advantages of the helical and multi-detector is basically to reduce the time, 3D image and reduce the motion artifact. Then there is a very common MCQ question, which is the Hounsfield unit. Hounsfield unit is basically, if you can remember the attenuation from the X-ray, this is the attenuation coefficient, and with water being 0. So the lower the Hounsfield unit, the less likely you will appear on the X-ray or the CT scan. It will be black. The higher the Hounsfield unit, it will be white. So what are the advantages of a CT scan? 3D imaging, better in soft tissue, better, of course, compared to the X-ray, and you can use contrast. The disadvantages, it's a higher radiation and lower soft tissue than the MRI scan. That will reach us to an MRI scan. What is the MRI scan? So the definition first is basically that it is a modality to create a high contrast image. That's the main aim of having an MRI scan, to create a high contrast image, which means that you have more details in your image than both the CT and the X-ray. It is superconducting magnet with a radio frequency coil and aiming to manipulate the hydrogen ions. So if you say these 3 buzzwords, you have answered the question of the definition. Then, now imagine that each proton is spinning around its longitudinal axis. So it has an axis. It's like you standing and actually spinning around 1 foot. But at the same time, you are actually spinning, your axis is rotating. That's called precision. Then we have something called parallelism. We will know what is that meaning in the next image. This is so much important. So if you can see that here, this is the longitudinal axis of the hydrogen ion or the proton, and this is its vector, and it's spinning longitudinally around this axis. If you can see that there is this axis actually is rotating in that direction. If you can see my arrow here, this is the precision. When you put these protons in a very high energy magnet, all the atoms will basically be parallel, because it's north and south, will be parallel with the longitudinal axis of the magnet. But the precision, everyone will dance in different beat. So all of them will dance together, but on each proton will dance with a different beat, because you can't control the precision. When you hit it with the radio frequency, so again, these are the red axes are the axes of the spinning, and the precision, you can see that each atom or each proton is in a different location in the precision circle, or the precision roundabout, I call it. When you apply a radio frequency pulse, what happens? All of them become precise, but they lose their parallelism with the longitudinal axis of the MRI scan. So all of them now going together precision-wise, but all of them spinning on an angle to the longitudinal axis of the MRI scan. Hopefully this is a bit more clear than usual, because this was a very important point in the MRI scan. Then when the radio frequency is lifted, 2 things happen. They come back into the longitudinal axis, and they lose their synchronization of the precision. All right. The loss of the synchronization of precision is the vertical relaxation point, but the loss of the actually the regaining of the parallelism with the long axis of the MRI scan of the magnet is the transverse relaxation time. Again, T1 is the longitudinal relaxation time, which is basically the loss of the synchronization of precision. T2 is the transverse relaxation time, which is basically gaining of the parallelism with the long axis of the magnetic field. That's so much important. Then few more definitions. You have the time of repetition, TR, and time of echo, which is basically between the time you hit the radio frequency and between the time you are receiving the waves back from the proton. T1 weighted, which the thing that you can see, and T1 is basically 1, so it's what one thing is white, which and T2, two things are white. That's how I remember them. So T1 it's only fat white, T2 is fat and water are white. Okay, T1 weighted, you have a short repetition time and short echo time, and this gives you anatomy. But the T2 weighted, it gives you pathology, and it has long T repetition and long time to echo. The steer is a way to do fat suppression. You don't need to know more than that in the MRI scan for the steer sequence. So the advantages of having an MRI scan is basically it's an excellent for soft tissue, no ionizing radiation, you're using a magnet and radio frequency, and you can use a contrast. It's called gadolinium, which is a magnetic, a pro-magnetic element. You have the disadvantages of that. It's expensive, not readily available, and there is the claustrophobia. And of course, in the conventional MRI scan, we have the image artifact. Now we have metal subtraction MRI scans. The next is the ultrasound. And the ultrasound, again, you have to know that the sound frequency is above the audible sound, and you have to know the transmission and the reflection. So these sound waves are transmitted to the body and hit the body, reflected back to the introducer or the transducer. Then it is transformed to the monitor. Again, it's composed of a transducer, which is the thing in your hand, a monitor, and the computer. And the waves are either hyperechoic, that means this thing is mostly solid. Actually, it's like a drum. It transfers back the sound waves. Or hypoechoic, it is less reflecting, it reflects these sound waves less efficiently. The advantages of the ultrasound is basically there's no ionizing radiation. It's good for soft tissue because it gives you the dynamic bit, and it's cheap. The disadvantages, it's that it's operator dependent. You don't have a hard copy to actually compare with previous images, or to ask another radiologist. There's no archiving with it, and it's poor in the bony anatomy. The next one is bone scintigraphy. It's a form of nuclear medicine, which is basically, it studies the distribution of a radio-labeled tracer by the means of detecting the gamma radiation that is emitted from this radio-labeled tracer. The most common used is technetium-99 M, which is combined with methyl phosphate, and that's why it detects the function or the activity of osteoblasts. and indium 111. How it works, so you have a gamma camera, and this gamma camera detects 3 phases. The flow phase, which is basically the arteriogram while the tracer is going to the bone. The pool phase, which is 5 minutes, and it is how vascular it is. And static phase, which is the 3 hours, this is bone activity. It has disadvantages and advantages. Its advantages are it's very sensitive and it localizes, but the disadvantages, it's more radiation than any of the other modalities. It's 2D and it's low in specificity. It gives you, there is a lesion here, but you don't know what lesion it is. It can be inflammation, infection, tumor, anything. Few words on positron emission tomography. It is formed of cyclotron, which is positron emission particles. And these particles are attached to a tracer, and this bioactive component, so we have the radioactive isotope attached to a bioactive element, which is usually fluorodeoxyglucose, and that's why it see what is the distribution of the glucose, and the tissues that are hyperactive use more glucose. That's why how it detects how high is the biologically active tissue is. You have the DEXA scan, which is basically for osteoporosis, and it's a dual energy X-ray absorptiometry, which you're using 2 types of X-rays with 2 different energy. And both of them, are aimed at a specific region in the body. The difference between the scattering the scattering of these X-ray beams is actually the amount of the bone mass density. So the bone mass density is calculated, and you should know the WHO definition, which is basically less than 2.5 standard deviation compared to a young adult of the same race and sex. That's the T-score. If it's the same race and sex but with age in consideration, that's the Z-score. And that is just for, okay, this is osteoporotic because it is pathological, not normal osteoporosis, so secondary types. Then you have the quantitative CT, which is basically has an advantage of a normal DEXA scan, is that it differentiates between the cortical and the cancellous osteoporosis. And you have the quantitative ultrasound, and basically it has no radiation. This is the report. Usually it comes like that, and it has 2 elements, a graph and figures. These are the most common parts that are detected: lumbar spine, hips, and distal end radii. There are positive, false positives and false negatives with the osteoporosis. The DEXA scan, like false, it can say that there is osteoporosis, so that's positive, but it's false. If you have lumbar laminectomy, of example, there is no bone enough. Or it can be false negative, like there's no osteoporosis and there is osteoporosis. And then if you are between -1 to -2.5, that's osteopenia. More than 2.5 standard deviation, that's osteoporosis, as you can see from the green, yellow, and red zones. So how many bones do you have in your skeleton? That's the question. Thank you very much. And now I believe with the MCQs.
Yep. Thanks, Joe. Thanks for that great presentation. I like the fact that you learn things in 3s. That's how I learned it, because it's quite easy to remember. And so everyone, we're going to go for the MCQ questions next. So we're going to share the poll. If you answer the questions as soon as you can, then we can move on and Joe will talk us through the answers to the questions. And then if you have any questions, we'll ask them after the MCQ poll.
So we can see, if you don't mind, Joe, just taking us through the answers and some explanation, please.
Yes. So first question is, where does the scattering happen in X-rays? You remember in I will read the answers first. So as electrodes travel between the cathode and the anode, that is actually 43%. As X-rays travel through the vacuum tube, well, okay, this is 7%. As X-ray travel in from source to body, that's 29%. As X-rays travel from body to receptor, that's 21%. Okay, so back to the scattering attenuation, the attenuation slide. We have three types of X-rays that after hitting the body, it's either reflected back or absorbed, so that's high beam attenuation, either passed through, that's low beam attenuation, or scattered. So it can't happen before hitting the body. That's the main point. It has to hit something so it deviates from the normal path. A scattering is not the spread of the X-rays. No, it is actually the deviation from a straight line. That's the main point. Okay, so I believe it's the fourth answer. The second one is during application of a radio frequency pulse. Of course, this is in the MRI scan. Synchronized precision and gain parallelism, loss of precision, gain parallelism, synchronized precision, loss of parallelism, loss precision, loss parallelism. So when you apply the magnetic field, all of them become parallel. All right, all of them become longitudinal axes. So all the axes become positive, negative, or north, south. But the axis itself, there is no precision between them. This is rotating like this. This is rotating like this as well. But they are rotating in different frequencies. So they can in different precision. Okay. But when you apply the radio frequency, you lose this parallelism, because they become, all of them become deviated, but they rotate, they have the same precision. So the answer will be synchronized precision and loss of parallelism to the longitudinal axis of the MRI. Then the third one, in positron emission tomography, the tracer analyzes what? Is it the glucose metabolism, the phosphate metabolism, calcium metabolism, amino acid metabolism? If you remember from the talk, it is combined with fluorodeoxyglucose. So it is the first answer, which is the glucose metabolism. Correct. Thank you. I think 79 answered the last one correctly. So that's a good one. At least one is good.
These are difficult topics, and very good questions, Joe. Thank you very much. I think you explained that really nicely. Great. I think, Nikki, you're here. So
that's right. Thanks, Joe. So I think David has got any questions?
So one question I know that's very popular, particularly with MRIs, gadolinium type 3, how does that help in terms of contrast MRI arthrograms?
Okay, yeah, gadolinium, yeah. So gadolinium is a pro-magnetic element, okay? It's injected to differentiate. So as an orthopedic surgeon, you don't really need to know how is it working, but you need to know why, because you are requesting plus or minus MRI scan, plus or minus contrast, yes? So that's the main point. So the contrast actually differentiate between fluid and fibrosis. In most the it is very popular in post-discectomy MRI scans to differentiate between, is it a new disc prolapse or is it fibrosis? If it's fibrosis, you don't do anything, because basically going there again and trying to do a surgery, it will not, it will cause more fibrosis. But if it's a recurrent disc prolapse, that's when you go and remove the disc. So it's basically to differentiate between two white things according to the affinity of it. Okay.
Fine, fantastic, thank you.
Oh, okay. That's anything else?
No, I think actually, well, you answered all the questions in your Viva, but in your presentation. I think that's it. Unless anyone else has any burning questions I'd like to ask, please put them forward in the chat box. But as I say, I do remember gadolinium being a very popular question when it's been answered, when they've asked about MRI scans in the Viva.
Yes, and usually it is with the recurrent, recurrent disc, or basically to differentiate between fibrosis and disc prolapse in post-discectomy, of course.
Yeah.
Okay, thanks, David and Joe. As far as I can see, there's no more questions. So what we'll do is we will stop the recording. I believe we have one candidate at the moment.